place where Albert Szent-Györgyi worked, who discovered vitamin C and received a Nobel Prize. But I'm not here to talk about antioxidants and vitamin C, but cytokine removal. And to understand the philosophy behind it, let me take you back to pathomechanism, how I see sepsis. And this is something we discovered several years ago, more than 20 years ago, with my friend Ewan Shearer in Liverpool. And we published this paper in which we published this figure. Because when we go to the ICU, you see patients who look very much alike. And regardless of the actual insult, they are all mechanically ventilated, receiving hemodynamic support, renal replacement therapy, artificial feeding, and you name it. Because any of these insults can provoke a host response via which the localized insult becomes the disease of the whole body, so it becomes systemic. Now let me bring this pathophysiology closer to you. One of the most important discoveries I've made over the last few years when I discovered an analogy between sepsis and love. What is love from the pathophysiological definition point of view? Love is a systemic inflammatory response provoked by somebody, okay? Just think about it. When you're in love, you are tachycardic, your temperature goes up, you're tachypneic, there is organ dysfunction related to it. Just think about altered mentation, broken heart, as cardiovascular failure, mortality. So, but most importantly, what is a message to this for us doctors, that we meet a lot of people, but not everybody has the same effect on us. And we do not provoke the same effect from everybody. So we must appreciate doctors, that we do the same for patients, and patients receive the same insults, but the response is different. So every patient is different. So it is not really the insult per se, but the host response which will determine severity and outcome. Just exactly how Sir William Osler observed it more than 100 years ago, that except on a few occasions, this patient seemed to die from the body's response to infection rather than from it. And now we have evidence that we are right. Fundamentally, there are two types of insults. One is damage, and the other type of insult is pathogen. Damage means direct cellular damage, like surgery, trauma, any ischemia, reperfusion. And pathogen is obviously bacteria, virus, fungi, whatever. Now, the striking discovery was that regardless of the insult, the released molecules are very much the same, regardless whether it is damage or pathogen. Now, taking the bacteria as an example, the mitochondrion is basically an encapsulated, from the evolutional point of view, an encapsulated bacterium. So any of these, gets damaged, then because their genetic background is very, very much alike, the same DNA and peptide will be released in the circulation. They will act on the same receptors on the monocytes. So this is why your patient with peritonitis, road traffic accident, and heart failure can have the same degree of ARDS after a few days, because phylogenetically they have the same roots. Now, we do suffer damage and pathogen-associated insults every day. You do hit your finger with a hammer like this boxer. His face will show all the signs of local inflammation. His face will be red, tender, swollen, but it will recover after a few days. Just like if somebody has a sterile damage-associated insult, like this knee replacement, this knee will look tender, red, and swollen, painful tomorrow, but this woman will recover in a few days and leaves hospital. And we do suffer pathogen-associated insults regularly, just like this ugly incarnated toenail. This will heal after a while, but you can see that it is also showing the local signs of inflammation and infection. And this will get better, just like when we have flu. We stay home for 5-6 days, and then we will get better. So we do suffer these insults, and systemic inflammatory response is a normal response. We need that, otherwise we would die. But why do we recover normally when we have a damage or pathogen-associated insult? We recover because we are healthy. So the second thing I had to come to terms in my head, how do I define health? And health, to me, is a balance between the antagonistic forces. In Europe, we interpret this yin-yang like a balance between good and bad. Wrong. It's a balance between antagonistic forces. And for us doctors, it has a very important message. because it's not like acid is bad, base is good. No, we need both, but they must be in balance, just like pro and anticoagulation, oxidants, antioxidants. I don't know what's happening in Belgium, but in Hungary, the pharmacies are full of antioxidants. Don't buy them, because it is a very fine-tuned system in our body. If you eat a lot of antioxidants, you will excrete a lot of antioxidants, okay? The only antioxidant I do recommend you to drink is Hungarian red wine, okay? It's the best stuff. Now, pro and anti-inflammation is very important. When it is in balance, we are healthy. So our immune system has the innate and the adaptive part, and they are in balance. You in this room, the immune system works on a baseline activity. So let's call the innate and the adaptive, for the sake of simplicity, the pro and the anti-inflammatory forces, okay? Now, when you're ill, your immune system changes gear, both the innate and the adaptives, both the pro and anti-inflammatory forces, and they will conquer the disease without any medical aid after 5-6 days. However, in our septic patients, this balance goes out of control. And for example, during the early phase of septic shock, the pro-inflammatory forces overwhelm the anti-inflammatory forces, and these patients can die at the early stage due to fulminant septic shock. And now this is nicely articulated in the new sepsis definition, as this is now defined as sepsis is organ dysfunction which is due to a dysregulated host response to infection. I like that. Mervyn used to say that for him sepsis is bad infection. Did you hear him saying that? So this is true. So there is a cytokine storm due to this imbalance between the pro and anti-inflammatory forces. In other words, the body becomes its own enemy. So it follows logic that removing the cytokines, we may just help the body to regain control. Now, sepsis definitions are nice and fresh, but this is a question I've been getting from my junior doctors on my ward rounds. Is this patient septic or not? And let me tell you, I'm not interested. This is a totally, utterly irrelevant, unnecessary question. To be honest, I have never ever treated sepsis in my entire life, and I have some bad news that you haven't done either. But we all treated patients like this one, and we did discover respiratory dysfunction, hemodynamic instability, renal dysfunction, altered mentation, acidosis, blood sugar, whatever, and we treated the organ dysfunction. So my message to you that you don't treat sepsis. You treat organ dysfunction and infection. Now, of course, we have to define infection, because if the critical illness is due to infection, you should give antibiotics or antimicrobials. But if it is not due to infection, you shouldn't give vicious drugs like antimicrobials to your patients. So, because it's not easy to diagnose infection, we use biomarkers, and unfortunately, these are called sepsis biomarkers. Wrong. These are inflammatory biomarkers, okay? Just remember that slide on the PAMP DAMP thing. These are inflammatory biomarkers. Now, there are loads of them, and undoubtedly, I've been working with PCT ever since it was released, and it has become my favorite. A bit more on that later on. But using biomarkers is not easy. It took me several years, I can say decades, to figure out how to interpret my biomarker levels at the bedside. Now, this is the paper we published, our philosophy on sepsis, and this figure, the first part summarizes the pathomechanism, and this is the treatment pyramid. So what we do to critically ill patients, you do your basic resuscitation, oxygen fluid, a bit of vasopressor, and many patients will get better, and then they can go to the ward. Then some patients, you suspect infection, and then you do your source control, antibiotics, surgery plus minus, and then they will get better, and they don't have to come to the ICU. There will be a patient group who will need organ support for longer. They will stay with us on the ICU. And there is a minority of the patients who just don't want to improve, and in this patient group, adjuvant therapy may become necessary, or at least indicated. Well, there are several things tested, like immunoglobulins, steroids, vitamin C recently, and extracorporeal cytokine removal is a new kid on the block, relatively new kid on the block. And using this device and putting into an extracorporeal circuit, you can get rid of cytokines, and with this you may just help to regain balance. However, this is not for sepsis treatment, but for any like burns, trauma, any type of cytokine storm initiated multiple organ dysfunction may benefit from extracorporeal cytokine removal. This is a large data set in which patients with pneumonia were analyzed, and what they found that the higher the pro and anti-inflammatory cytokine levels, that the greater the chance of dying those patients, and this is reflected in the mortality risk ratio as well. So how does this device work? Well, there are biocompatible porous beads in this cartridge, and they form a huge surface, 4 football pitches type. I don't know, I haven't measured it, but it was said. And it absorbs anything which is less than 55 kilodalton. Now, you can use it in your extracorporeal circuit during renal replacement therapy, and you could put it after the filter or before the filter, or you can use it on its own like hemoperfusion. Now, what do we have so far? Well, we have a lot of experimental data, and I'm not going into details because most of these animal studies come up with the similar or same conclusion that those animals treated with cytokine adsorbent, it does attenuate inflammatory response, eliminates inflammatory cytokines, keeps the infection localized, helps to keep it localized, and improves hemodynamics. We have a lot of case reports published over the last few years, and again, I'm not going into details because most of the case studies come up with the conclusion that the treatment seemed to be safe. It did attenuate inflammatory response mainly by procalcitonin IL-6, improved organ function, and most of these patients were about to die, so treatment was really initiated as a last source, and most of them survived. We have a Cytosorb registry led by Professor Brunkhorst from Jena. Several countries are involved, and the first interim analysis, we just published it over the last few months. And the recruitment rate is going up nicely in a linear fashion. And the first interim analysis, in this we had 135 septic shock patients treated with cytosorbent. What you can see here, that the predicted mortality was very high, 80%, and the observed mortality after treatment was only 65%. So we concluded that this is a good signal. Now we have the 4th interim analysis. It has not been published. Now we have 210 patients in the septic shock arm, and what you can see here, that we had the similar Apache 2 and SAPS-2 score like before, and this was higher than in other studies. So we really treat patients all around the world with cytosorb who are really ill and have a very high risk of dying. And the mortality, again, around 62%, 66%, significantly higher, substantially higher than in large studies like the VICEP study or the Prowess shock and so forth. So we apply the treatment for really critically ill patients. And it also seems that most of the patients admitted into the registry have a Apache 2 score above 35 or anything between 25 to 35. And the higher the Apache 2 score, this is the predicted mortality and this is the observed. You can see that the sicker the patients, it seems that there is the more benefit of the treatment. There are clinical trials. This is a clinical trial. Well, I don't think it was a very good one. It was a trial performed between 2008 and 11. I haven't even heard about Cytosorb at the time. And they randomized 100 patients with pneumonia caused ARDS. And they only treated them for 6 hours. But they possibly started the treatment quite late. The mortality risk was more or less low in this patient group, and they couldn't find any difference in the IL-6 concentration over the 7 days of the study. Now, they concluded that the adsorber did reduce IL-6 level because they measured it before and post-filter adsorber. But by and large, it was a negative trial. Now, this is a series of cases, 20 cases, very high risk of dying. As you can see, patients with septic shock, again, above 80% risk of dying. And this is the time when the cytokine adsorbent treatment was commenced. So the patients were really in dire straits, increasing noradrenaline dose, decreased lactate clearance. And after the treatment started, everything got better. And eventually, they observed the patients had very high 25,000 IL-6 level and high procalcitonin level. And then the mortality, what they observed, was only 55% as compared to 80%, and there was shock reversal in 65% of the patients. And this is, again, a recent case series studied. These were 26 septic shock patients on renal replacement therapy in whom hemoadsorption was applied. And what they found, that the sooner the patients received the treatment, the better was the outcome. The predicted mortality was 90% in these patients, and eventually they observed only 62. However, when the treatment was commenced 48 hours after the onset of septic shock, the mortality was 100%. So their conclusion was that hemoadsorption improved survival in this patient as compared to the predicted. And now we reach our study, what we have just recently completed. This is the ACESS trial. It is adsorption cytokines early in septic shock. This was a pilot proof of concept study on 20 patients randomized into two arms, control arm and the cytokine adsorbent arm. And we had a very strict inclusion criteria. The sepsis had to be of medical etiology, and within the onset of septic shock, patients had to be included in the study within 24 hours. They had a respiratory dysfunction requiring mechanical ventilation, PCT greater than 3 nanogram per milliliter, norepinephrine greater than 10 mics per minute, invasive hemodynamic monitoring confirmed cardiac output, signs of hypoperfusion, but renal replacement therapy was an exclusion criteria. Now with this, we were aiming for a homogeneous group of patients, and we managed to finish the recruitment of the 20 patients within more than 2.5 years. And I'm working on a large volume, 36-bedded ICU. This just reflects that if you use a homogeneous inclusion criteria, you end up with very low recruitment rate. Now, a few words on this, whether PCT is an appropriate marker of cytokine storm. Well, this is preliminary data from the study. We measured all types of cytokines, and what you can see here, that PCT showed significant correlation with most of the measured pro- and anti-inflammatory cytokines, so maybe a useful biomarker to monitor cytokine storm at the patient's bedside. And it is also a good marker to monitor treatment effectiveness. This is a study, this is my colleague Domonkos, he wrote his PhD out of this study, and these studies, because there are two. And we compared the PCT kinetics within the first 24 hours, measured 8 hourly, and compared patients who received appropriate antibiotics as compared to those who received inappropriate antibiotics. And what you can see here, that PCT keeps doubling in patients who get wrong antibiotics, but in patients who get appropriate antibiotics, it reaches its peak around 16 hours, and by 24 it is already coming down. So it may be a useful marker. This is an area on the curve which shows an 86% chance that just looking at the degree of PCT change, the kinetics, you may define patients who are getting right or wrong treatment. So using PCT kinetics may just be a good indicator of cytokine storm, and also to use timing and monitoring efficacy in your patients. I can share with you the fresh results. We just analyzed a part of the data 2 days ago. So hot from the oven. These are my PhD students, especially Fatima, did a huge work, working all day and night to get some data out. So we only had 10 patients in the control and the cytosorb arm. 2 patients died within 48 hours. In the control group, nobody died within 48 hours in the other group. And this is the age, the length of stay, and these patients were a bit sicker, but it's due to the small numbers. Now, the primary endpoint for the multiple organ dysfunction score at 48 hours, you can see that there is no difference between the groups. However, procalcitonin over 48 hours showed a bit of change here in the control arm, but there was a steady and significant decline in the cytosorb arm. C-reactive protein is not absorbed. There is no difference between the two groups. And there was again a significant difference between the two groups regarding the vasopressor need. In the control arm, there was no really change in vasopressor need. However, in the cytosorb arm, there was a dramatic and significant reduction in norepinephrine requirement in these patients. So yesterday we had a seminar meeting on cytosorb with 4 colleagues from Western Europe. And what I suggested, when we do now, after this study, a large prospective study, that we do need early recruitment. We need homogeneous population. We need mechanical ventilation. We should aim for inclusion criteria as higher PCT, higher norepinephrine. I think the others are fine. And possibly we can easily include patients who need renal replacement therapy. Finally, let me share with you how to individualize treatment with PCT. I'm sorry, but I was told that I have 30 minutes, but I will finish in 3 minutes from now on. So when we put clinical picture into the context of PCT change and time, then you will end up after 24 hours with 3 groups of patients. One who is too ill to do any more than what you have already done. There will be patients who will get better. Then again, it doesn't make any sense to do anything differently. And within that benefit, the gray zone will be patients in whom there is no improvement and clinically, and the PCT doesn't show improvement either, so they may need some extra help. So finally, this is a real case of ours, a 42-year-old woman, acute abdominal peritonitis, admitted to the ICU, received fluid resuscitation in theater plus norepinephrine, and she was started on antibiotics. Now, on arrival to the ICU, she required 60 mics of norepinephrine, and she was on 8 of PEEP on 55% oxygen. So 2 organ failure and a very high PCT as well. So I'm sure our chairman, Mervyn, would say it's bad infection. It is. This patient is septic. So because of the high PCT, 163 nanomole per liter, and the high norepinephrine, I'm pretty sure you all agree, just like Mervyn Zinger and Konrad Reinhardt, that this patient is in septic shock at this phase. So we carried on, it's 6 hours, we carried on with basic resuscitation, and the patient didn't seem to improve within a couple of hours, so there's still a huge vasopressor requirement, so it's going from bad to worse. So in our routine practice, we put an invasive hemodynamic monitoring in, and the PICO revealed a fluid-responsive patient. So we gave more fluid, and we tried to stabilize her. There was a bit of improvement, but still it is going bad. There is persistent cardiac shock and overwhelming inflammatory response, and 6 hours gone by, so we had enough. It was midnight, so I'm sure that Mervyn would agree that this patient may need some extra help. And this is when we commenced cytosorb treatment in this patient. Why? Because we've done the basic resuscitation, source control, organ support, and the patient just didn't get better. And this is why we decided that she needed some extra help. And within 3 days, we treated her just once for 24 hours, and then the noradrenaline was down to 10. The patient was extubated, PCTs down to 53, urine output and renal function improved. So it was a happy ending after all. What do you think? Was it due to cytosorb? Was it due to the antibiotics? Was it due to both? Or was it due to the patient herself? No one can tell, neither can I. So this is the beauty of treating these patients. It is a very complicated issue, and you may not just find the right solution, but in this case we had a happy ending, and Mervyn congratulated me with a glass of wine. The picture was taken on Sepsis, where I strongly advise you to come, and if you are a junior doctor, less than 29, it's free registration. So if you want to come next year in November, you can listen to the prestigious faculty for free. If you are older, you pay the registration, but we can still have a cracking good time, and you can enjoy our departmental rock band's concert on Thursday night. Thank you.